All right. Today I have a special guest, Phillip Fulgham. He serves as the Vice President of Hospice for Saad Healthcare. He has led the hospice service line since 2017 as part of a family-owned healthcare organization based out of Mobile, Alabama. He's going to talk a little funny, but he's a good guy. His academic background includes economics, business administration, with a degree from Birmingham, Southern College, and Auburn University. So all my Alabama fans out there are going to be mocking this one a little bit, and I have a lot of them.
Oh, goodness.
Spent a lot of my career in Alabama. Alacare was one of the first big agencies that we rolled out. You know them real well. And then, of course, Saad and all them. And so I spent a lot of time in Alabama. Phillip, welcome to the show. Give the listeners a short version of your path into hospice. How'd you get to Saad?
Yeah, well, it's awesome to be with you, Tom. The family business was started over 50 years ago by my grandparents. And so we began in the long-term care space and then got into home health and hospice in the 80s. And so it was something I was always around. Parents worked in it. Really built the business with the home health and hospice business, where it was really a product of my parents. It was kind of on the tail end of my grandparents' career. And then, with me, I'd say I was in a construction pathway and I really enjoyed that. But to be honest, there was kind of this moment where I was running my own construction company, dealing with a lot of subs primarily. And it was a little lonely, it was kind of like every day you're basically going to job and it's kind of by yourself. And I really wanted to be a part of a team again. And so reached out to my parents. I said, hey, I think it's time to come in with the family company in 2010. And we were about to make this transition to home care home base. And I have always been inclined towards technology. So I led that effort in the beginning and began to learn home health and really worked primarily in what we were doing in home health for the first 7 years I was working with the company. And then the opportunity to lead our hospice came. We were building this inpatient unit that I'm in right now. And given the construction background, I was really very much involved in it. And so that opportunity was presented to kind of steward this part of our company. And I took it, and it's been an incredible ride. And I think one of the things that really drew me to hospice is I've always been a man of faith, and I felt like hospice was just a perfect extension of where my heart was. And it really has proved to be the most rewarding work I could have ever imagined. I wouldn't trade it for anything.
That's awesome. Congratulations. Are your brothers and sisters in the business or just you?
Well, my sister for a while was a speech therapist with us, but when she started having children, she took time from that. And so her husband does work with us. So my brother-in-law, and then my brother, I have one brother, he is leading our home health division.
Yeah. So your Thanksgivings is all you talk about home health and hospice. That's what you're saying. Mom, dad, brother, sister, brother-in-law. Yeah, it's crazy, isn't it?
Yeah. And my aunt too, she leads our home health and hospice over in Mississippi, and my cousins work in it now. So it's definitely a family affair.
My family is, my stepsons work with us. My wife works with me and her sister. And that's all we talk about is home health and hospice at Thanksgiving too. We actually have rules like stop. All right. We're not going to talk shop. Yeah. We're not talking shop at all. It's crazy. Yeah.
Yeah.
Tell us about the business. Tell us about Saad Healthcare. How big? Where are you at? Where do you serve? Tell us about the company.
Yeah. So we serve the southern half of Alabama, the southern counties of Alabama, and then also the coastal counties of Mississippi. We're kind of a big fish in a small pond, you might say. We've pretty well established here, have nearly 1,000 patients on home health. On hospice, we've been as big as 300 patients. We've been kind of around 200, a little less lately, but it's kind of where in this marketplace, our name isn't so weird to people because they've known it for a long time and really just serve this market. We do want to continue to grow. We want to expand in Alabama, but we're not just in some sort of aggressive growth track of trying to get into a bunch of states.
So expand around Alabama, maybe a little bit more in Mississippi, maybe some touch of states. That's great. That's good. All right. You're the Vice President of Hospice. What does that mean? Tell the listeners what that means every day. What do you do every day?
If I were just kind of describing my primary duties, I think, first of all, I'm responsible for our culture. That was something when we built our inpatient units was a really incredible challenge. It was one of those things with culture that even when I took over in 2017, there's setting the standards, kind of the expectations, but also the heart of what we do. And what that looks like really is different things. Like right before I came on the podcast, I was meeting with some new RNTs, and I like to be able to just listen and kind of give them an idea of who they're working with. I think from day to day, it's really just seeing some of the problems that we have. I've really worked hard on trying to solve some of the problems that are easy to solve. The ones that a lot of times are technology based are pretty easy to solve. Sometimes the coordination of care, the way that we're set up. If you're really listening to your staff, you can kind of understand where the pain points are. And that's kind of from a day-to-day perspective. I think those things are where I interface. I think at the beginning I was very, very much in everything. Every chat, every, communication, I was watching and listening. And what I would say is both for um the hospice, home hospice product, and then also what we're doing in the inpatient units, once you get the culture going, it is like a train. It's hard to get started, but then it does move with less need for attention every day. And a lot of that is because you get people in there who really represent your culture well, and so they're able to make sure the new people coming in continue on what you've said. So I don't have to watch chats as much. I have really good people, and allows me to really spend more time developing cool solutions to stuff and areas where we can grow, and dealing with some of the challenges we'll talk about with ADRs and different reimbursement related things. I'm able to put a lot of energy into those things.
That's awesome. All right. So you have a hospice. You guys call it a hospice house or just an inpatient unit?
We call it inpatient. We have two. We have one, this freestanding facility. It's 24 beds, and then we have a 15-bed unit in one of the local hospitals here.
Oh, that's awesome. All right. Describe the difference between those from a staffing perspective and care perspective. How do we decide where someone goes? Are they close enough to decide, or is it bed capacity, or how do you decide?
Well, bed capacity is definitely one of them. I think we try to keep our freestanding facility is really just an incredible place. And if anybody who's watching can go online and see it. We really tried to take some time to look at facilities in the nation that were designed and built really well, and poured a tremendous amount of love and attention and money into building a place that we felt like represented what we thought families needed during this time. And so we try to keep our freestanding facility available for our home patients. We do bring in a lot of patients that are coming straight from the hospital here, but our hospital-based facility is a really good partnership with that hospital. I think their goals are certainly to get patients into the inpatient unit, at time of death. So and there's some financial realities they really leverage with that. But I think too, when you've got patients who have a difficulty transferring from the hospital, even just a few miles, you don't want to risk them dying in transport. So having a facility that's in a hospital is really useful in that way. And of course,
Yeah.
we went in and made the unit look beautiful. We tried to make it as much like what we have here. It just doesn't quite have the space that we have here, but it's still a wonderful place to be.
It's awesome. I've visited all the big hospice houses around the country, and there's some amazing ones out there. I've never been to yours, but one of these days I'll come and visit. It's
Yeah, well, then you could really give a good impression on where it stacks up.
yeah, it's the best one I've ever seen. There's two. Empath now used to be called Hospice of Palm Beach County, has one right on the beach in Florida. It's amazing. I mean, the views are
That'll be tough to
unbelievable.
beat. Yeah.
Yeah, and then Rocky Mountain Hospice had a hospice house that was literally donated, and they spent like $40 million. It was right on the cliff of the mountains. It was unbelievable. Like, okay, those are the two
Okay,
places I
those will
want to
be
go.
tough to beat.
Yeah,
They will.
just the views are amazing. The facilities are great too. And then I know,
Well, maybe we can get a top 5 ranking from
yeah,
Tom.
sure, for sure.
I'll put that on our website.
Yeah,
One of
that's
the best.
it's amazing what you guys do in the hospice houses. I mean, most people will tell you they're a loss leader and all that. They're a great marketing machine, but when patients really are struggling and they need it, it's amazing what happens in those hospice houses and facilities. And
Yeah.
when we were building back in the day when I was building home care home base, we were building the inpatient unit technologies, and so we went and visited a lot of them, and it's pretty wild. The computer on wheels, they call them cows, which nurses never like that. But so hospice is getting a lot of scrutiny right now in the press and the news. A lot of it's in Southern California. You don't hear much about Southern Alabama, which is good for you. You hear a little bit about Texas, a little bit about Miami-Dade County and some of those. But your thoughts around what's going on, and then how do we, make sure that this isn't an overall United States impression of hospice and more just a territorial impression? Thoughts around that?
I think for a lot of hospice providers like me, it's kind of a gut punch because the the biggest problem in hospice is not these issues. To me, the biggest problem is short length of stay. It's patients choosing hospice too late, and I could talk about that this entire podcast. It is still the biggest problem, and it's when you're delivering hospice at the level that we try to deliver it, you have such an incredible thing to offer people, and for people to have any reason not to choose it on top of the ones that are already there is why it feels like a gut punch. I think, when it comes to the fraud, it's good in a sense, like that they find the people who are, really taking advantage of the system. I think that they, with what I see with the SSVI metrics that they're putting in, I think some of it is not quite getting to the heart of the problem. I'm trying to put together, I saw on your previous one, you're putting something together as a response. I'll send you mine because I really tried to go through each one of those. And some of them are really headed to the right direction, but they're hitting it, I think, wrong. Like, for instance, the one on payments outside of hospice or Medicare spending outside of Part A hospice. That one's weighted wrong. They should go after it on a per patient basis. I don't know why they're doing it in these big lump sum numbers, for instance. I think they're trying to find the problem. I will say that, but they need to look at it. They really need to talk to more hospices that are doing a good job, because I think those hospices can really help them find the problem.
I did a Last Visit First podcast a couple weeks ago, just a piece on the new rule change in proposed rule change. But it was like 28, 27, I forgot the exact number, of the number of hospices that don't submit their claims data. They don't, I mean, they submit their claims, but they're not submitting their HOPE data and the HCI data previous. I mean, start there. I mean, that's the easy one, right? If you're not submitting your data, if you're not saying, hey, government, we're going to be transparent with you and here's your data, like, my opinion is they should shut off the payment until you submit your data. They're saying we're going to give you a 4% hickey. Well, 4% hickey, if you're fraudulent, is terrible. Shut it all the way off. If you're not submitting your data, then turn it off. Like, if you don't submit your OASIS claims, you're not going to get paid. If you don't submit your claims, you're not going to get paid. By the way, if Cole doesn't turn in his expense report, he's not going to get paid. Why wouldn't we just shut it all the way off? That's the one that blew my mind. I was like, that many, 27%, that's where all your fraud's at. Those are the guys that are, if you're not going to be transparent and submit your claims level data or the HCI and the HOPE data, why wouldn't they turn that off? And so now this SSVI is going to address that a little bit. But I was listening to the Sean Ryan show, has a podcast. He's an ex-Navy SEAL, pretty good guy. He's a little bit political, and he has a lot of opinions. He's a big weapons guy and gun guy. And I served in the military, so I like to listen to him. But he had the kid on that's kind of exposed all the Minnesota fraud and and he's really did a big thing in the hospice side. And I mean, this guy's getting death threats and stuff from these gangs of, people that are out there. And it's really controversial, but he went to one place that was 253 hospices in one building. And when he knocked on the door, nobody was there. And he describes it in detail and talks about it. And so that's the stuff that embarrasses me in this business. It's sad because there's people like you that are really trying to, do the right thing and taking care of a lot of patients and building hospice houses and you have nurses going into these homes and then they read the news and the news is just smearing everybody in hospice. It's really kind of sad. It's something that I want to fix.
So I think you've got these just abject fraud happening, and then you have the people delivering hospice that need to be called up to a standard. And I think I'll give you a good example. So I think it's the first metric they've got, where if you delivered GIP or continuous home care, then you get a point for that. The problem that I have with that is it should be if you delivered GIP or continuous home care on a patient that had more than a certain number of days of routine home care on your hospice. Because the thing that they need to target is your ability to care for patients through the end. And I mean, even bereavement, but we can talk about that too. I love what we're doing with bereavement, but you get what I'm saying? It's like any hospice can pick up a GIP or two at the hospital and get a one on that. But then there all these metrics, all this stuff that they've done to try to go after visits in the last week of life, I feel like are just hitting at the bigger problem, which is as a hospice, if you're committing to take a patient, you are going to support them. And the idea being early in their care, it's not going to be as much visits needed. But as you get further to that point where they need a lot more attention, you are willing to do it. And that's
That's good.
why with a GIP unit like what we've got going on here and at Providence, it's such a expression of where we are, was because I wanted to be able to offer to our patients at home the best possible experience at end of life. And, not everybody's in a crisis and needs it, but
Yeah.
generally they are.
Yeah. Not everybody wants it either. I mean, not everybody wants to go to a facility, but some people do. And so you having
Yeah,
that facility and having all options for them is amazing. It's good. Yeah, I like
that's
it.
right. Yeah.
My grandma died at home, and you've probably heard this story on the podcast. Her name was Nana. By the way, a lady
Yeah.
sent me this book right here. I don't know if you can see it or not, but it's called Nana Upstairs, Nana Downstairs. It's a kid's reading for grieving children, but it
Uh,
talks about little Tommy, and I was little Tommy. My dad was Big Tommy. He's not bigger, man. He's older, so they call him Big Tommy, and I'm little Tommy. But it's a great comic, or not comic, but a storybook. And a lady sent it to me that we wrote a bereavement software, and she used it. And I always talk about Nana, and that was the story behind it. So, but not every Nana needs to. I mean, my Nana wanted to die in her bed at her home with her dog and her
absolutely.
TV remote control and
Yeah.
all that. And we had that experience. But if we'd have needed a hospice house, we would have found one. And that's
Yeah.
really important. So the HCI metrics that are coming out of the SSVI now, they're calling it. The other one that I see a lot is the, long length of stay. And, Jimmy Carter was on, President Carter, let's call him who he
Yeah. Yeah.
was on service for a very, very, very long time in hospice. And that benefit was amazing for him. And so we all know that the hospice benefit is a 180-day recommendation, but it's not a requirement of 100 days. You don't have to discharge before that. But there's all these
Right.
ADRs that are coming out around long length of stay patients and making sure they're hospice eligible. As the leader of the hospice, how do you address that? Talk about that a little bit.
Yeah, it's a good one. Because we've had to deal with that. And there's really a few ways that I would say we've approached it. I think first of all, with palliative care, one of the really high it's not really a great product in terms of the reimbursement for it, as I'm sure most people listen to this podcast knows. But I do think one thing that it helps with is having a way to transition patients who've maybe have plateaued or aren't really declining enough to justify continuing on hospice. So that's probably one strategy that's really helped, because I think before we had a really robust palliative care plan, the ability to get a patient into a safe situation after discharging hospice was difficult, especially if we kind of taken over their care for quite a while. So it allows us to continue to be involved in their care, but just monitor them until they're ready to come back on again, which has been great. The other thing we've done is I've really worked hard, and I know you get into AI, so and I love that you say clinical intelligence, because it really is what it is. And
Right.
one of the biggest struggles we've had is you bring in clinicians who've never really known how to chart in hospice, and you've got this massive, you know, education that you're having to give them, and the time frame for them to learn it is not usually enough for them to be able to get good at it. So, we've really developed a tool that helps us with the both tracking of patients' decline and then also being able to tell the story of their decline, both from
Yeah.
a narrative and from an IDG standpoint. And that's been massive, because when you're talking about a patient who's on for a while, decline isn't, typically these big macro changes. They're micro changes. They're changes in appetite. They're changes in functional status that are sometimes very small steps down. And so to be able to kind of have something that really helps the nurses explain why a patient's continued stay-on hospice is needed, what value we're bringing to the home when we're visiting is been game-changing for us.
Sure. And then do you use your medical directors to train that, or you use senior nurses, or how do you do that?
Kind of both. We've used some kind of best in industry education on it. We've worked with our clinical team, and kind of where it started was, before even we had the ability to kind of put in this AI piece on there, was we really just sat down and said, okay, what are the critical things that we should be tracking for decline? What are these metrics, you might say? Because I saw this problem where it was like, we need to quantify what's going on. It isn't enough to just say the appetite's poor. You have to really quantify what appetite poor is and how does that compare to what the appetite was before. And so we sat down with our kind of best clinical minds and talked through it, came up with the I just would call it like the components of decline. And then it was really just recently now that I kind of felt like in the beginning when we were looking at it, there was still too much hallucination in AI. So I didn't really trust that it could do what we're now having it do. But we've been able to get it to where now it's able to really put together a comprehensive story that helps the nurse to produce a great narrative, to have an IDG note, whether it's confined to just what's changed in the last 2 weeks or whether it's been over the last the month or the entire benefit period, so that they're not having to spend as much time going back through the chart, finding all these changes that have happened.
Yeah, I mean, think about that. How was Nana, how was Nana's appetite 6 weeks ago? I got to go read 60
Yeah.
charts in order to see how she was, or I can
Go
tell
see
AI
that.
to go tell me, go measure it. Especially if you're putting some kind of scoring around it, it's really easy to look at it. And I agree with you. Your appetite's poor. Your weight loss is good. Well, is weight loss good? 5 pounds, 2 pounds, 1 pound, 7 pounds, 10 pounds?
That's
Weight
right.
gain, if you have a CHF patient, is weight gain of 5 pounds overnight. That's a big deal. But is
That's
weight
right.
gain 5 pounds over 2 weeks? That's not that big a deal. I mean, maybe their appetite's better, or eat more chocolate, or
Yeah,
they
and
drink
then
more water. And so, yeah, being able to quantify that's going to be really intelligent.
yeah, and they can't remember. It's hard for them to remember, for a research. They might be remembering months of data and having their ability to just kind of know, okay, they had some falls, they had multiple UTIs, all these things stack on top of each other when you're talking about a patient who's on a longer trajectory.
It's awesome.
Yeah.
So what's your favorite tool in using? Are you using Claude or OpenAI or ChatGPT or Gemini, or what's your
We're
favorite?
yeah, we're mainly using Vertex, so
Vertex.
Gemini. So Gemini in their cloud platform, it's been a good partner for us, and yeah, it's been cool.
Yeah, I'm interviewing some Carnegie Mellon interns to come work for me this summer. Just to, I want them. These guys are I call them kids, but they're college kids, super smart. And one of the things that one of the guys said to me was, "Don't fall in love with one tool, because as soon as you do, the next one's going to be out." But as a
Yeah,
as a developer, you got to develop towards one of them or the other one. So yeah, Gemini's a good one
that's
for
true.
that. But it's amazing how fast things have changed. I mean, I was talking to Elliot Wood, the CEO of Mosaic, yesterday, and I mean, he's like, "Holy cow!" I mean, our industry's changed overnight. I mean, and then
It's
every
nuts.
night it
It
changes.
is.
Every night it changes.
I think what we're building, probably like in the bigger sense, is what I would call like a hospice brain. Something that understands hospice and its ability to then interface with where you need it. And
It's
so it's
awesome.
kind of a process of training it to see. And that's where kind of this other thing we've been working on is speaks to kind of length of stay on the other side, is patients choosing hospice too late. And we can get into that as it relates to referrals and these kind of things. Cause one of the challenges in facilities, we have really strong facility relationships, but one of the things that I've noticed with the inpatient unit is it fits into what they think hospice is. So oftentimes conversations that are being had are really, I guess maybe we put it differently. A lot of the referrals coming from hospitals are not patients that are going to be on hospice very long. They might be a couple weeks, they may be a month. A lot of times they're just a few days. And so really where I see the opportunity right now is more in our home health census. And so that's kind of been the project I've been working on most recently is getting this hospice brain, you might say, to really look into HCHB, see the actual documentation the nurses are doing, layer in the hospital documents, and give us an idea of who is ready. I really kind of based it on this palliative score, which is called the surprise score, and it's, would you be surprised if this patient died in a year? And I think that's such a great starting point when you're talking about someone's appropriateness for hospice. Like if you would not be surprised that they died in the next year, then those conversations for hospice need to start. And I think that's where we're kind of missing it, is that we're waiting till we have these obvious clinical kind of just massive cliff moments. And at that point, they're really probably a few weeks.
Yeah, it's yesterday there was an article, Hospice News posted an article that I read. By the way, I use AI
Yeah.
to generate all these articles and then tell it what it means to Maxwell and tell it what it means to the podcast and all that, which is
Yeah.
phenomenal. So I don't have to go read all these, but it summarized it. If you elect hospice, if all
Yeah. I
hospice
saw
patients
those.
elected hospice 5 days earlier,
Yeah.
it would save $1.9 billion. That's a lot of money.
Yeah. That's why it's so crazy that not more attention is given to extending what's available to people, with the ability to kind of make sure hospices are discharging patients who have plateaued. And I mean, of course, starting out trying to take patients that are appropriate. I mean, you've got guidelines for that, and I think those work really well. I mean, all of our tools are kind of trained on what the guidelines are, so we don't try to make someone fit who doesn't fit. But honestly, there's just so many patients who are in that terminal trajectory, and I guess kind of the feedback loop that I'm trying to create is, as we have these conversations with home health patients, and let's say there's a reluctance, or there's just some barrier. They want to try rehab, they want to continue with that, being able to continue to follow them and then kind of feed that information back in so that you get a better understanding of, was it right? I mean, eventually what I'd like to prove, Tom, is that a lot of patients, their life is extended on hospice, because I think, like, anecdotally, that's true. And I think most hospice providers would agree that for a tremendous amount of patients, the getting them out of the rehospitalization loop, getting them into a care model where they're being managed really well, actually creates a amount of stability that extends their experience. And yet it's difficult to prove that to be true, because there's not enough comparison. Like, this patient's in the same place as this one chose hospice and they lived X amount of months versus this one who lived this other amount. So
Yeah, but you think about, though, de-prescribing medications. I did a podcast with Dr. Kimbrell. I don't know if you know him, Jason Kimbrell. He used to run, it was called Optum Care RX.
yeah,
Super smart guy, great pharmacist. And so him and I did it. And I mean, just de-prescribing the medications that are no longer
yeah,
needed, right? Why are you on a statin? Why are you on all these other medications if
that's
you
right.
know that you're going to pass away in the next 6 months? We know that you're declining. And so if we can keep Nana around for 3 or 4 more days, or keep Nana more comfortable for 3 or 4 more days, because we're de-prescribing all these medications, which are causing her to have leg pain, which are causing her to have, take more morphine or take more Oxycontin or hydrocodone or one of those. I mean, just de-prescribing medications, just, making sure she's comfortable, making sure that the family's around her, making sure that the
Right.
family knows she's passing away, keeping her from being sad, lonely, depressed. I mean, all those things are going to extend, at least, even if we don't make them live longer, we're going to make them live happier longer. And,
That's right.
and that's really important. And so, yeah, I think what you guys are doing is cool. The whole de-prescribing of medications is something I'm really spending a lot of time on right now. It's, there's so many drugs that are being taken in hospice patients that don't need them. I mean, he tells a story.
That's true.
Dr. Campbell tells that story about, a patient family member called him up and just wearing him out. And she's like, I can't crush these medicines. And, Nana can't take these medicines. She can't swallow them. They're too big. So I'm trying to crush them. And he's like, okay, which medicine are you crushing? It was a multivitamin. Like, I mean, I'm
Yeah.
sorry. What's
Yeah.
a multivitamin? And like, she's like got it
Yeah.
between 2 spoons with a hammer, smashing these pills so that Nana could take a multivitamin. Why is she taking a multivitamin? Come on, let's make that a lot easier. And then you start looking at these home health patients, and I see them all the time. Literally eating a bowl of cereal of medicine. And
That's
I
right.
take 5 pills a day. They're all, vitamins and aminos and all that. And I could barely swallow the 5. And then you sit there and go, okay, Nana, you got to take 22 pills. Some you got to take with food. Some you don't take with food. Some need more water. Some are in the morning. Some are in the afternoon. Like, how do they figure all that out? One. And so that's what a home health nurse is for. But then two, you look at it and you're like, you're swallowing literally a full handful of pills. I mean, that's a meal. And then
Yeah.
what are those doing to your stomach? And I'm not anti-medicine at all, but we also have to look at holistically. Nana went to the cardiologist. She went to her endocrinologist. She went to her primary care, and they're all prescribing medications that solve whatever problem she has. She's got swelling in her feet. She's got leg pain. She's got something going on with her heart. She's, retaining water. And so all these different medicines, and sure, there's interaction checking and we all do that, but you really start looking at it. I mean, these complex medical patients that are on, 8 or more polychronic medications, pharmacists really need to dig deep and figure out what's going on with them. And most of the time in the pharmacy, they're just trying to get your pills, filled as quick as you can and get you out of the way. And it's unfortunate, but
Yeah.
I think we do cause a lot of the pain and the problems.
Yeah, we've seen that one of the biggest benefits of having a facility with respite, the ability to deliver respite, is a lot of times you have the chance to have those in-depth conversations on the medications because they're bringing all these in. You're like, okay, let's go over these. Why are we taking them? And have those family members understand, that some of these are not needed anymore. And a lot of our de-prescribing actually happens over respite. Not that our nurse can't do it. A lot of times our nurse practitioners will do it, but respite seems to be a great place for it to happen.
Yeah, define that. Most people don't do respite. It's one of the least used benefits there.
Yeah.
Describe
Yeah,
respite
it's
a little bit for the
crazy. It's
listeners.
like one of the most amazing benefits.
It
I
is.
really think like respite is where I stand on, if hospice, which I think is one of the best designed programs of all time, it really is incredible. If they didn't intend patients to be on hospice for some amount of time, then why would they have put a respite benefit in? Like that just makes no sense. And it's basically, 5 days at a you can be at a nursing home, or if you have a facility, it can be at a inpatient facility. It has to be an approved facility. Can't be at like an assisted living or anything like that. But yeah, it just gives the caregiver a break. I mean, it gives them a chance to go. A lot of times they may need appointments that they haven't been able to keep for their own health. It may be some, I was talking with my friend's dad whose mom's potentially coming on hospice. And, he was talking about how his dad, who loves baseball, has never seen or hasn't seen his son play high school baseball because just the amount of responsibility he has to care for his wife, which is true. But to be able to give him a gift to just like, hey, go and see him play, it could take some time to do that. And sometimes the husbands and wives have a harder time choosing respite. We've had some where they want to come and stay here with them, but for those sons and daughters that need a chance to go see maybe their daughter, their son, it's a huge, huge blessing, and it's one of the coolest experiences. I love walking around and seeing some of our respite patients just sitting with our nurses or just talking with, playing games. We'll have a lot of volunteers come and help with, working with those patients, whether it's just doing a puzzle or, giving them some interaction while they're here.
Do you watch Landman? You ever watched
Which
it?
one?
Landman?
Landman? I
Yeah.
want to. It looks really
Oh,
good.
watch it. It's really good. There's a scene in Landman where Billy Bob Thornton's dad is Sam Elliott, and he's sitting outside he's in a nursing home or assisted living care center, and they roll him out and let him watch the sunset in West Texas. It's in the oil country, so it's flat, and it's where I grew up. And he makes a statement. I can't remember exactly what it is, but he's talking about you don't ever get to watch. Someday you're never going to get to watch the sunset again. And he just sits there, and every night he's there. Like they show it over and over and over in multiple episodes. And it's somebody thought enough for this man that he wants to see the sunset. So they wheel him out there in his wheelchair. He's out there by himself. He sits there for 20 minutes and watches the sunset.
Yeah.
But he makes a statement about it. And I'm like, oh man, it kind of hit me really hard. Like,
That's
oh man,
good. Yeah.
it's, someday you're not going to be able to watch the sunset. And so he
Yeah.
wants to watch every one of them. It's pretty cool. And it's what respite's about, right? Respite's about
It is.
giving the family a break and taking care of them. All right. You guys do a lot of continuous care too. Continuous care is an underutilized benefit as well, where the patient's really in a crisis and we're spending a lot of time with them. Most of the time, these are really dehydrated patients or really complex patients. They're having a lot of pain. We're trying to manage and cycle their pain. We're trying to, use a MACI catheter or IV or some kind of injection to give them, manage their pain. Talk about that early identification of continuous care. You figured that out in AI as well?
Well, I'd say, haven't put towards that. I think, like I said, I feel like we do some elements of hospice really well. So when you got a patient, there's typically signs. I mean, I will say that what we're doing with our decline, we call it decline sense with that product. It is typically seeing patients who are getting closer to terminality. I think that usually that's coupled with us increasing visits. So we're seeing them pretty often. And it really becomes a question of where the family is oftentimes, and then where the symptom, if it can't be managed well at home, that's when we're going to intervene. And yeah, I mean, before we had the unit, the way I worked, I was just telling some orientees that we would have LPNs who were set up to where they'd come on for the day and, have patients that were maybe being seen more often, which has hurt us with that, the whole measure, because you don't get credit for LPNs going to see patients. But regardless, we had them set up to kind of deal with PRN issues, but oftentimes they'd also start the continuous care. So what was surprising to me is when we built these units, I really thought that my competitors would get heavy into continuous care because their sell could be to people, hey, we'll just keep you at home and that's where you want to be anyway. But they really didn't do that, which was surprising because that's what I would have done, and if anybody's listening to this in another place, like having the ability to deliver continuous care at home is such a huge, huge benefit to families. So the way we would do it is just have the LPN start it. So they kind of, because they're hourly, they were able to kind of get it going while we worked with our private duty to get the rest of the shifting set up. And it worked really well. I mean, we were able to do quite a few cases at the same time.
HCHB is proud to sponsor the Last Visit First podcast, which explores the complex issues faced by today's home health and hospice providers.
In the spotlight today, Chief Revenue Officer Hannah Pearson, explaining how HCHB uses technology to connect people.
One of my favorite phrases is relationship architect. The focus is about the client and building the right community, the right fabric of community around our customers, making sure that from the very bottom to the very top, they had a resource and a contact to reach out to with any problems, and that we could connect them quickly and expeditiously to the right resource. That's where the client success team was born, and we touch people at every level of the organization.
CMS just issued one of the most significant regulatory actions our industry has seen in years. And it's a clear signal that operational integrity, clinical documentation accuracy, and compliance readiness matter now more than ever in home health and hospice. At Maxwell Tech, we help agencies strengthen the operational and technology foundations needed to succeed in this environment. From clinical chart reviews and regulatory compliance assessments to workflow optimization, analytics, and operational readiness, our team helps organizations reduce risk, improve their visibility, and operate with confidence. The agencies that will thrive in this next era of healthcare will be proactive, data-driven, and operationally disciplined. And that's exactly where Maxwell Tech comes in. If your organization is evaluating compliance exposure, preparing for growth, navigating acquisition due diligence, or simply looking to tighten operational processes, now is the time to act. Contact the Maxwell Tech team at sales@maxwelltech.com to schedule a compliance and operational readiness discussion.
Also like to thank our sponsor, IntelliTriage. IntelliTriage is a human in the loop, nurse first triage company that simplifies the triage function inside the home health and hospice community. You can reach them at IntelliTriage.com. Talk to me about, this is a little controversial, but why in the world or why in the heck or whatever term you want to put in there, I could think of 3 or 4 other ones. Would the government of the United States say an LPM shouldn't get reimbursed the same as an RPM in a crisis patient with a hospice patient? Like, I do not
I have no
understand that one.
idea.
I
I
do
really
not
don't.
understand it.
And that's where it really hit us on that metric, because when it first came out, I didn't pay attention to that. That's on me. But I was like, what do we do? We're giving tons of visits right here at the end, but I will say that I think they're also, by taking GIP out of that denominator, it's hurting it in general, because if you're just looking at how many patients before they died had a visit, and then for a company like ours, and if there's others watching, maybe they've seen this too, where they're moving them into a GIP or moving them into continuous care, those are kind of outside the metric now. And so a lot of kind of where we get scored poorly in that is the patients who die. A lot of times on hospice, you have patients who just died in the night, like you weren't expecting it. There wasn't any particular kind of symptomology that was making it clear that they were going to be terminal. And everybody's kind of surprised. And so those are always going to be there. But when your denominator is lower of patients that you had visits at the end with, it really kind of unfairly penalizes companies that are doing CTC or CHC and GIP.
So we have
Does that make sense?
Yes, it does. It absolutely does. We have a need for nurses. We're desperately needing more nurses. We have the ability to go train LPNs or LVNs, depending on which state you're in. They can pretty much work at the top of their license and do everything they need to do in hospice.
Yeah.
But we're not going to count them in the denominator. We're not going to count them as visits in last day of life.
I don't get that at all. Like, honestly, I have no explanation about it.
Yeah.
Because they count this medical social worker in those visits. So, I don't know what the reasoning is there.
When I'm dying, by the way, I really want a chaplain around more than anything, but we're not going to count the chaplain.
I
want a
chaplain either.
I want the chaplain.
Yeah.
And I probably want an aide too. Like, I think there should be a metric around how many aide visits you're doing. Because when you look at it, like in all the hospices that I'm involved in, when you look at the responses, nurses get, great credit and all that thing, but the aides, man, I get so many letters about
100%.
aides. My aide was amazing. My aide was an aide. And the aide is your most impactful person to your HCAP score. I promise you, if you have great aides that fall in love with their patients and patients fall in love with them, you will have amazing HPAS scores, because that's what the family's going to see. Those are the people that are doing the things that nobody else wants to do. Aides are amazing, but we don't count them. It's like, come on,
it doesn't make any sense. You're 100% right.
Figure this out.
And they typically develop. We have patients that are pretty often getting 5 days a week of aides. So those are the people that are the closest to the family. They're in there every day. They're, the ones that are giving them the most help for what they need. And I don't understand why that's not considered such a critical part of what the hospice benefit's able to provide.
And the other one that I was an EMT paramedic before I went in the military. I don't understand why EMTs and paramedics aren't part of this. Firefighters, these guys are doing, they're EMT paramedics. They work, 3 on, and then they all do extra shift work, whether they're moving your furniture around or trimming your trees. All these firefighters have second and third jobs. Why aren't we hiring all the firefighters in the United States and ambulance drivers and all that, paramedics, EMTs, to go help us in the home health community? We have a need. We have a patient demand. They don't count. And so I don't understand why CMS hasn't figured this out.
Yeah, that's such a great point. Yeah.
Dr. Oz, listen to this. Hopefully he will. Or Secretary Kennedy.
No, he's saying, hopefully he will. You need to send it to him.
Yeah, I'll send it to it. He'll never listen to it. But they're looking at all this stuff, and I keep going back to, there's ways to solve these problems. The other one that I think is crazy and hopefully they listen to it, but the number of RN degrees that are being issued from colleges and being licensed is very small. And so there's some kind of controlling factor of the number of licenses that get issued. And so we have more RNs trying to go to college, trying to become an RN, but they can't get a license because they limit the amount of license they're getting. And I don't know if it's a control for pay or control for volume or make sure their standards are good or whatever. I don't understand that one either. Like, let's open the door up, let as many RNs. Sure, you got to pass school. Sure, you got to pass clinicals. Sure, you got to get your license. All those things, agree totally. Yeah. But why don't we have 10,000 of them, instead of 1,000? And then the whole other one that's total controversy for me is this whole compact state or requirements for each state. Like, if I promise you, an RN in Alabama and an RN in Texas are doing the exact same thing for the patient.
Yeah.
So why can't your license move to Alabama? If my husband's in the military or my wife's in the military and I get transferred to Alabama, why do I got to go reapply for a new license? When I went to the best college, I went to Baylor University or University of Texas and got a nursing degree. And now when I go to Alabama, I got to reapply for my license. It makes no sense to me. So there are compact states. I get that there are compact states, but it makes no sense to me. Same thing with doctors. Should doctors move? They got to go reapply for school and do all that. It controls the amount of physicians that we have, nurse practitioners, PAs. Those things blow my mind, and we could simplify them.
I think they should also give more opportunities for doctors to get specialty work after they've already started practicing. I've heard from several medical directors that they really want to get more education in hospice and palliative care, but there's not a lot of like certifications. There is some kind of certifications, but not like the really big ones. They can't really get those while they're already past that point in their schooling. I think that would
Yeah.
help a lot.
Yeah. So once you pick your specialty, you're kind of stuck with it unless you go start over,
Yeah.
which is
Yeah.
tough. It's tough. And you may pick the wrong specialty. Like you may be a radiologist and decide, hey, I'm tired of looking at x-rays. I want to go see patients, or vice versa. Yeah, there's a big problem with that. So I think the government can release a lot of these rules and relax them, let's call it, and make it easier for us to. If we don't, we're going to be in a problem. We're going to be in a real problem in this country. We have more people that are turning older. They're living longer. AI is going to help that, continuously help that. Hopefully, we're going to live longer at a better quality. But I mean, if we want people to take care of us, we're going to have to find them. And by the way,
That's
going
right.
into people's home is one of the hardest jobs in the world. You're knocking on a door
It
of a
is.
stranger and going into their home, and so.
Yeah, that's right. It's hot in the South in the summer, and it's not an easy job for sure.
And, I mean, it's a elderly person that's in their home that's probably not, especially if they're, somewhat at their end of life or in hospice, more than likely their spouse. And it's probably not the cleanest, most friendly environment in the world. And
No,
so we're asking people to do the really hard job. And then we're saying, hey, we're going to restrict you on who can do it. It's tough.
that's right.
What else you want to talk about? What else so you read the rule, you read the final rule or the proposed rule that came out. Anything else in there that's controversial that you want to talk about or that you're going to write about?
Yeah, I guess, well, I might be wrong on this. I mean, you can look this up. But on the spending, what was confusing to me on it is that when I looked at it, it seemed to be these buckets of dollar amounts of Medicare spending outside of hospice, right? Which would seem to penalize the large volume hospice more than the small volume hospice. And that's something I may be wrong, and maybe somebody watching this podcast can correct me, but if I'm not wrong, the way I ran the statistics on it was 83% of the hospices that had over 300, the buckets they put them in is like 25,000 patient days or over 300 beneficiaries. And those people, the hospices in that bucket, 83% were 5 and above on that score. Whereas if you run it by a per patient day, if you're like taking in the volume into account, it was basically 50-50. 50% were less than 5 and 50% were over 5. So that's concerning to me because it seems like it'll target a lot of your bigger hospices like us, in an area where you really, we were a 5 last year in the bucket methodology, but if I run in the statistics by where we are on a per patient day, we were a 2. So, things like that are definitely concerning.
So here's let's go controversial on this. They're doing it by PTAN, which is most people are going to fall in that middle tier, of their PTAN, 100 to 200 AEC hospice. There's some bigger hospices out there, but most people have that. But then we're going to put a moratorium on the number of PTANs we could do. So what is that going to do? If we do a national moratorium, which by the way, I think in certain areas, they absolutely should do a moratorium for all the fraudulent hospice. But if we do a moratorium, what are we really doing? We're restricting care. And so if I don't want you to become a big branch or a big PTAN, and so I want you to have multiple PTANs, but all I'm doing is restricted care. I'm going to keep more patients from going. My measurement is nobody should die on home health. Nobody should die on home health. They should always die on
That's
hospice.
right. Yeah.
We have a lot of patients that die on home health, and I'll explain that here in a second. But thoughts around, so that they're doing it by PTAN, which I understand that. So it keeps the giant hospices or the giant home health agencies from being scored all together because they have multiple PTANs. But then you're going to block the number of PTANs that we can have, which is interesting to me, which is going to restrict care. It's going to restrict care. It's going to make me drive farther to go see that hospice patient or say I can't take that hospice patient. So I think they've broken the model there.
Yeah, I agree.
Now, the reason I think why is because they've never run a hospice. So you're making
That's true.
rules. The people in CMS that are making the rules have never run a hospice. They understand it from a data perspective. They understand it from a policy perspective, but they've never sat in your seat and had to go talk to that patient.
Yeah.
And if they had more people that sat in your seat, they would change those.
Yeah. Well, and I think too, the other one that kind of, maybe it's just where we are, but in this, you might have people who listen and don't like what I'm about to say. So you can cut this out if you want. But I think they should lower the the nursing home percentage, patients on hospice in a nursing home to 20% max. Like, I don't think it should be 40%. And part of that is just because I think it creates anti-competitive behavior. I think it makes it to where nursing homes will take away patient choice. We've had a lot of patients that tend to, oftentimes they don't have every option of nursing home to go to, so they have to go to the one that accepts them. And then, that nursing home works with XYZ hospice, and so we don't have a chance to get in there. And those kinds of things I think are a real negative. I don't like that. So that's just me personally. And maybe if I was one of those 40%ers, I would be not saying that, but that's how I feel about that. So
Yeah, it's
I want that one stricter. So
yeah, I mean, but I truly believe that they go to the National Association or the Alliance, they call it now, and they get a lot of advice from the Alliance. They get a lot of advice from, bigger hospices that march on Washington or whatever they call it. But when CMS is really making these rules, and I know they're trying to sit down with the Alliance to do that, but if you really sit down with the operators and say, okay, these are good, compliant 4 or 5-star hospices, patients love them, they have all this information. What's bugging? This, like the whole nursing thing, the LPN thing just blows my mind. Like, I love LPNs, I love RNs, but right now we just need as many of them as we can get. And for you to scrutinize or penalize or not pay us as much or not count our visits, it drives me bananas. And it's just not fair. And so, but I get it. If everybody should work at the top of their license and we should have as many RNs as we can get. But if we can't get RNs, we can get LPNs or we can get paramedics or EMTs or aides or chaplains or social workers. Why not count all those visits? I mean, I promise you my chaplain's visit is just as important as my nurse's visit. And my social worker may be more important in certain situations with family members. All right. You mentioned your bereavement program. Talk about that a little bit. What are you guys doing in bereavement?
Yeah. I was pumped to talk about this. Yeah. I mean, it's been amazing. I mean, when I started running hospice, I really was committed to a lot of the operational problems that were needing immediate attention, and those kind of really took precedent. And then we started really developing our care model where it was delivering a high quality experience. And then when we built our facilities, it was, able to step that up. But the one area that I felt like we were still kind of, not really great in is bereavement. And where I really saw bereavement, I saw it in 2 ways. Number one, they are the only people who can kind of represent what you did. Like, they're the word of mouth people. And so to pour into them is an opportunity to kind of create a really strong kind of raving fan, you might say, person in the community who is telling people about what they received at our hospice. So that was one area, just from a economical standpoint, you might say. But I think the main genesis and kind of the driver behind it was it's so rewarding, And so what I realized is, you can send out letters and you can do the kind of support that is required to do, and that's awesome. And you can invite people to come to some of the other things you've got going on. And a huge percentage of them, they don't need it. That's not where they are. And it took me a little while to understand it, because I was kind of in this place where everybody needs this. Everybody should be here for support groups, for what we're doing with our weekend retreats and these kind of ideas that were just so profound. But what we ended up kind of realizing is, no, there's a subset of people who are struggling the most with their loved one passing. And to be able to provide them those services is kind of the goal behind doing more in bereavement. And that's where we've set up support groups. We've got 3 that meet here every week, have incredible camaraderie. These people, they lost, some of them, especially with the men. We set up a men's group on Mondays. And what you see with the men is they've really lost their purpose. A lot of them had spent the last several years, particularly husbands, have spent the last several years caring for their wife. And they really, had become their community. And so to re-engage them, the guy who leads it, he was in our other support groups, and he was like, I couldn't get a word in with all those women. And so he was like, I wanted to get a men's group started.
That's awesome. That's awesome.
So it's been cool. And where that's really kind of then stretching out is into our volunteer, because, before we were partnering with schools and having social work interns and we have a physician relationship with a school here in Alabama that still sends us physicians to have an internship here, kind of a not an internship, but whatever they call it. And that's been great. But the bereavement was the opportunity that I saw to develop the best volunteers. And that really has proven to be the case. Now they're so engaged in daily just hospice experience, whether it's helping us, some of them join our prayer team, some of them help us with letters and sending those out. Some of them will just come and, if we're doing a celebration of life, they'll help just kind of staff that event. It's really remarkable. And then, we've got these men, they're like now wanting to do a yard service for patients who need help. And so I'm like, yes, like this is what I'm talking about. I really want to see it to where we're just like hosting the volunteers doing the care. I mean, we would do the medical care, but like they're creating the experience. And that's kind of where I see that going one day, is where, you come into our facilities and the volunteer influence is so powerful that, people can't really distinguish like who works here and who doesn't,
It's cool.
So,
And who gets paid and who doesn't get paid, right? That's cool.
yeah.
We, so I don't know if you know, I'm just in a commercial for Maxwell Text products, but I created a product called Bereavement. And so what we did is we took all those letters that you're mailing and all those outreaches and turned it into text-based communication, which is phenomenal. I'll tell the backstory on it. So I was working with the largest hospice, so you can probably guess who it was. And I sent it to their chief compliance officer, and she asked the question to ACHCs, can we turn bereavement into a text-based bereavement? But she asked the question, can we text bereave? Can we turn our bereavement program into text? And of course,
Yeah.
ACHC said, absolutely not. We're going to give you a condition level survey every time you do that. And I'm like, whoa, wait, I spent, millions of dollars building a bereavement platform. What are you doing? So I called up the lady at HCAC and I was like, all right, let me demo the product to you first before you judge it, what we're doing. So you still go through the bereavement risk scores. You still do all the things you do in home care and base today, but instead of mailing a letter, I'm sending you a text link, which has some information on it, but I'm giving you a link back to your website. And on that website, I can refer a friend. I can have a suicide hotline. I have all the resources, videos, and all those things. Amazing. So she started crying. She literally started crying on the phone with us, and me and Desiree and Andy were on there. She started crying. She's like, I can't believe you actually are the first ones to create a bi-directional bereavement. So when we send you a letter and you tell us, thank you, Saad Hospice, you're the greatest hospice ever. Well, by the way, as soon as you do that on the first bereavement interaction on day 6 after Nana's passed away, or day 2, I grab that information. Now I give it to my sales team because I know that Nana was the patient. I know that the bereavement contact was tied to Nana. I know the sales team is tied to her, and I know the doctor that referred her. Now I'm walking into the doctor's office going 3 days later, hey, Nana passed away, really sad.
Yeah.
But here's what they're saying about the care we provided for them. It is unbelievable. Like I
That's
get
awesome.
my team sends me these messages all the time. They're like, hey, check this one out. And they'll break your heart. Like we had one lady that said, the social worker convinced me to get in bed with my husband. He died in my arms. I looked outside and the fountain changed colors. I know he's in heaven. I'm like, holy cow.
Oh,
Like that would
love.
just like
I love
rips you.
that.
Oh, you love it, right? But so
Yeah.
here's the other tip, and you can do this with or without me. So a lot of our hospice now are doing bereavement for life, just like you said. I have the most
Yeah.
experienced bereavement. I have the most experience. I have the raving fan, as you called it. I have a raving fan of this hospice organization. So now I'm going to use it I'm going to continue to send bereavement letters after the 13th month, every month. Hey, just
Yeah.
checking in on you. If you need anything, we're here. We have these support groups. You want to come help us mow yards? Great. If you want to scoop snow, you guys don't have snow in Alabama, but in Minnesota, if you want to come scoop snow, if you want to crochet blankets, if you want to be a volunteer, we're here for you. Anything you need, we're your hospice connection. I promise you, if you've had a positive hospice experience, you're going to have another friend or family member or sister or cousin, brother, aunt, uncle, postman, somebody in your family is going to ask you about hospice. And what you want them to do is remember Saad. You want them to remember, hey, this is where you should go to get care. We went to this
Yeah.
facility. It was the most amazing experience ever. And so you want to be top of mind all the time for them. It's amazing. So we're now doing bereavement for life. It's not expensive. By the way,
No, I love
your
that.
your government, the United States government's going to raise stamps to 95 cents this summer. Somewhere between 90 and 95 cents.
Expensive.
It 20%
It is.
increase. 20%
Well,
increase.
we those addresses better be right. We see that. That's real for sure.
It's
But
crazy.
on that, we need to talk about that more because I see an opportunity with bereavement to like expand it to the, like, you know, it's kind of taken as like our responsibility as the hospice, which it is. But if you think about it, like, how do we get it geared back to the community that actually knows and loves that person? And I want to talk to you about that at some point, because I got something that I really feel like would be incredible to do that. And it's just little things, but it would be through text. So
Yeah, I already have the platform ready to go. It's unbelievable. By the time we release this podcast, we will send out 1 million bereavement letters.
that's amazing. Yeah, I
That
love
is
it.
amazing. And I'm telling you, the responses you'll get are unbelievable. You could spend all day just reading the responses, and you get a lot of thank yous and hearts, and we don't need you, but
Yeah.
thank you. Don't, but a lot of times they'll say, hey, I don't need this, but my family does. And when I was working with another big hospice, and we were looking at the web statistics, and we're like, okay, we sent 2,000 letters, but they had 3,000 people go to their website. And we're like, and so I'm yelling at Scott. I'm like, Scott, fix this. Our calculations are incorrect. What we found is they were forwarding that on to other family members because they wanted to hear the story that this doctor, they have a doctor that they posted on their website, and he has a great message about grieving and, the stages of grieving and all that. And so they were forwarding it to all these other people. And so they were going to the website. So we thought our calculations were wrong. No, our calculations were right. They were just forwarding that text message because it's really easy to forward a text message. And so we just, that train volume. But I mean, what would you pay for, if you had 1 million text to 1 million bereavement contacts? I mean, that's like unbelievable. That's marketing at its best. And you're also doing the right service. You have your Veterans Day, you have your Mother's Day is one of the biggest ones. They'll have a, celebration of life, Mother's Day celebration of life kind of thing. Those are big ones. So yeah, those are awesome. Bereavement is an area that, it's expensive to use as a hospice, but there's ways to use it as a tool inside your organization and then still take amazing care of all these people.
Oh yeah, and it's incredible. That's my worry with like palliative care. If it became bigger, is that you start losing these like unbelievable elements of what they put into the hospice benefit, with bereavement being one. I mean, I think it'd be terrible if we weren't responsible to care for the family as much as we care for the patient. Like, I think it's one of the real just guiding lights of being in hospice.
Yeah, so. I agree with you. I agree with you totally. Well, if I want to work for you, Philip, how do I get a hold of you?
Yeah, well, you can go to our website. Yeah, for sure. Look at, send me a message on LinkedIn. That my name's on there. Yeah, any web communication is going to probably get to us before anything else. So, yeah.
That's awesome. All right. So what's the website? Is it Saad Healthcare or SAAD.com?
SAADhealthcare.com. Yep. Mm-hmm. SAADhealthcare.com. SAAD Healthcare.
Yep. Cole will post that on the show notes. All right. Last question, legacy question. When you're done, your mom and dad, you're ready to retire, you're ready to give up on this, hand it to your children, hopefully. By the way, I'm going to make a comment here. I'm amazed at the number of people that's mom and dad worked in home health and hospice that continue to work in home health and hospice. Yeah. And you're probably the 10th or 11th one that their mom and dad, hired them in the organization to file papers or move boxes or, keep the lights on, and they fell in love with this business and they stayed in it. So congratulations to you on that one. But when you're done, what do you want your legacy to be? What do you want people to remember you as?
I knew you were going to ask that. That's a big question, Tom.
That's a good one, though.
I mean, it's awesome to be able to do something every day that means so much to people. I think the legacy, probably just if we're just talking about around hospice, and I think something that, you get to a point in life and you certainly want to do big things and accomplish all these great things. But at the same time, what I've seen happen is some of the greatest reward is just in the simple things. Like, to give you an example, we do chapel here every Thursday. And there was a chapel service where I was coming back and I was reflecting on this environment I was in, this healthcare environment that was very stressful. The whole environment felt very anxious. And one of the things that I love that people say about our building is that it's peaceful. Like, it just feels so peaceful. And when I was in chapel, I was just so thankful for the ability to create and host an environment where people feel God's peace here. And so I expressed that out loud. And this lady comes up to me with tears in her eyes and just telling me what this place meant to her for the loss of her husband. And during that same time, I was going through some tough ADRs, like some really difficult situations where, payback money, a lot of money situations that was horrible. And and I was just like, God, why? Why are we dealing with this, right? And it was like what I heard in that moment was, is the struggle of what you've been through worth these tears? And when I thought about it, I was like, you know what? I would trade the money to be able to deliver this experience, to deliver beauty at the end. And that's really probably from a work perspective what my legacy is. But I caveat that to say, like, you know, the thing being like where I am as a father and as a husband, you got to be careful not to lose that while you're in the midst of this, because honestly, that really is the legacy we leave behind is our children. So being able to be there for them, that's one of the best things about being in a family business, is that you get to attend the games, you get to, get home and enjoy like the little moments, go on vacations. It's just not missing this moment in life. So, in 20 years, I may have a different answer to the question because, they'll be older. But right now, I'm really just loving being able to care for people in this environment and, you know, also be able to be a father and a husband.
It's awesome. Think about the number of lives that your parents, your grandparents, you and your brothers, sisters, brother-in-law, everybody else that works there are touching every day. I mean, I always think about it.
Oh,
And
it's amazing.
I don't know
Oh,
if
it's
you looked at
incredible.
if you listen to the April Anthony podcast, I mean, it's one of the things we talk about is the number of lives that she personally has touched. The same thing with you guys, whether it's the
Yeah.
nurses that are getting to pay for their kids to go to Alabama or Auburn or wherever you want to go to school. Just kidding you. Auburn and Alabama hate each other if you guys didn't know that on this podcast.
Yeah.
But and I always I'll tell you a funny story. So Stephen Waits, Alacare, Stephen probably.
Yeah.
Um,
Yeah.
we're doing an on-site visit with them way back in the day, and I'm a big Texas football fan, and so we're having this big dinner. It's I don't know, it's some restaurant, and he had figured out how to get them to play the Auburn Texas game on the TV right when we walked in. And it was
Oh,
after
goodness.
they'd whooped our tails in the national championship. And so he's like, oh, I just wanted to make sure you remember this. And I don't know, he plugged in some kind of a thing to the TV and they replayed it right there. And we had to watch this whole game reenact all through dinner. He wouldn't turn it off. And I'm like,
So it was
you're
a
lucky you're
replay?
my, yeah, it was a replay, like over and over and over. Like you're lucky you're
That's
my
cool,
customer.
man.
I'm like, you're
Yeah.
lucky you're my customer. And I'd make you turn this off or I'd break that TV off the
Yeah,
wall.
that's
But
cool.
but
Yeah,
I
they
mean,
take it seriously here. It's a
oh
big
yeah.
deal.
But talking about all the
Yeah,
people that you guys have influenced is pretty amazing. And the number of patients that
it
you've
is.
touched, the number of people that have gone through your
Oh, man.
facilities, the number of caregivers, the number of people that are on home health that got healed and now they're better. I mean, it's pretty cool to have that
Yeah.
legacy of what this family's done.
No, it's
So
incredible. I mean, serving our community just like when it comes to just being in a business that affects the lives of the people you live with in the community. I would say this is up there. No, I don't know many others that do that touch as many people or are able to like serve as many people as home health and hospice. So everybody in the industry who's in this, like, it's such an honor. It really is awesome.
it
So
is. Well, Philip, thank you for being here. Amazing day.
yeah, thank you for having me. I loved it.
Yeah. Yeah. Thanks for sharing your story.